Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of epilepsy. Dr. Travis Brown, epilepsy is something that touches many families and sometimes unbeknownst to them. It's one of those sorts of conditions.
It can come out of nowhere. And epilepsy can be actually a very scary disease when you don't know what's actually happening to your loved one. People talk about seizures, and this is very challenging for families, particularly if it's a child who's experienced it. But sometimes the amazing thing about epilepsy is it can be adult onset as well. So people don't realise that. It's like, but I didn't have it as a child, but it is adult onset. But seizures is one of those quite interesting diseases. Is our understanding has developed over time, but seizures go all the way back into biblical times. Like, this is history written, and there is just seizures now back in biblical times, and actually probably throughout most of history. It's been associated with demonic forces, and this has been the interpretation of life. And one of our first quotes actually comes from Mark 9 in the Bible.
A man in the crowd answered, "Teacher, I brought you my son, who is possessed by a spirit that has robbed him of speech. Whenever it seizes him, it throws him to the ground. He foams at the mouth, gnashes his teeth, and becomes rigid. I asked your disciples to drive out the spirit, but they could not." "You unbelieving generation," Jesus replied, "how long shall I stay with you? How long shall I put up with you? Bring the boy to me." So they brought him. When the spirit saw Jesus, it immediately threw the boy into a convulsion. He fell to the ground and rolled around, foaming at the mouth. Jesus asked the boy's father, "How long has he been like this?" "From childhood," he answered. "It has often thrown him into fire or water to kill him. But if you can do anything, take pity on us and help us."
And so you can see the interpretation there. And from looking at the Bible, you actually, when it's translated from the Greek, which eventually was translated from the Hebrew, the actual word they use is interpreted as to be moonstruck, or affected by the moon. And look, there's other quotes about seizures, and this is from Matthew 4.
News about Jesus spread all over Syria, and people brought to him all who were ill with various diseases, those suffering severe pain, the demon-possessed, those having seizures, and the paralyzed, and he healed them.
Even when we're looking at other writers in this time, we're looking at ancient Roman. So this is where you're looking at Suetonius, Appian, Plutarch. Now, they wrote about Julius Caesar, who believed to have had seizures. And they talk about, him having these sudden fainting fits. And Appian says that Julius Caesar had convulsions. And Plutarch called this distemper of the head. And so Plutarch even wrote one time when Julius Caesar was listening to Cicero that he had these seizures while he was listening.
His body trembled, and some of the papers he held dropped out of his hands, and thus he was overpowered.
And so that was an interpretation that the speech had set him off, that he was just overwhelmed with this, amazing, speech from Cicero. So, there are seizures. And if you go into Julius Caesar's family, like the writings of his history, there is this seizures going through. Now, whether that's true or not, again, a lot of things could be interpreted that way. But there is the element of seizures. And this is where we come to today of our understanding of epilepsy, our management, our treatment has come amazingly far. And this is why we have our guest today to help us to say, where are we in our understanding of epilepsy?
Professor Mark Cook is a Melbourne-based consultant neurologist who is internationally recognised for his expertise in epilepsy. He is trained in London and completed his medical doctorate as a brain research fellow at Queen Square. Professor Cook is the Director of Neurology and Chair of Medicine at St Vincent's Hospital in Melbourne. In 2023, Professor Cook was awarded an Officer in the Order of Australia for distinguished service to neurological medicine and research through contributions to the treatment of epilepsy. Professor Mark Cook is our guest on this Medical Life podcast. Welcome, Mark.
Good morning. How are you both?
Very well. We wouldn't be anywhere else on a Monday morning. Now, you actually have a family experience of epilepsy. Can you tell us about when your father was diagnosed?
Sure. So my dad developed seizures when he was in his 40s, late 40s. And, these were eventually revealed to be due to a cerebral tumour. Remember, this was sort of pre-MRI days, so it took a little while with CT scans of one thing and another. But even after he had surgery for the tumour, he still had seizures quite frequently. And these were obviously a big problem for him because he works as a chef. And that's a fairly dangerous environment for someone who has seizures that involve loss of contact and confused behaviour. So that was very difficult and led to him having to stop work. But also he couldn't drive, and we lived out of town. We lived outside Lilydale and the outskirts of Melbourne, and so he was a bit stuck then. So this kind of magnified his problems further.
How did he manage the illness itself? Was it lots of medications and trying different things?
Yep. So all the medications that were available then, really, there was only three sort of widely used anticonvulsants: Tegretol, Epilim, and Dilantin. And, he was on all of them. And how he managed it was he'd go to his doctor and give his doctor a completely inaccurate account of what was going on. And the doctor would, then increase or decrease or add or subtract medications. And it just went around in circles there a little.
Was he able to still work and everything?
No, he had to stop work. But no, he didn't manage it very well because he was, very embarrassed by it. Like a lot of people, he thought, he didn't really know much about epilepsy, but he knew that it was something bad to have and it was terribly stigmatising, as it remains for most people. And so that part of it was probably as difficult for him to manage as anything else.
And what was the impact on family, yourselves?
Well, because we lived at a place where he worked more or less, it's a long, complicated story, we sort of had to move, so that the family had to move, and, my brother had to, I was at university by then, but my brother had to change schools, and it was pretty disruptive for everyone.
And were his seizures ever able to be under control?
No, they were never controlled. He had limited awareness of them, so that might have been good in some ways, but it increased the hazard a great deal.
Did you ever experience seeing him have a seizure at all? Was that? Yeah,
absolutely. So I can remember the first time I saw him have a seizure was, watching TV one Sunday night with him and my mum, and he got up and went to, he sort of got up and rushed into the kitchen. It was a bit odd. My mother rushed after him and closed the door, and I couldn't understand why. And they'd obviously been going on a little while, but they were trying to conceal them from me. Again, just because my dad was so embarrassed by them.
Were you studying medicine at this time that this was happening?
Yeah, I was, but I didn't have very much knowledge about seizures then because, you learn a little bit about it, but it's still something which probably most doctors don't have a very good grasp of, the nature and the management of seizures. It's despite being a very common illness, so it's strange.
Even to this day?
Yes, even to this day. Yes, I'd say it's probably one of the areas that doctors feel least comfortable and least in control of when they're seeing people with this. They're unfamiliar with a lot of medications. They're not sure of the hazards involved in particular medications. They tend to be a little fearful of them. And I don't think it'd be an exaggeration to say most people are frightened by seizures in the medical world, generally frightened by managing them.
And how common then is adult onset epilepsy?
Well, look, it's pretty common. There are peaks of onset of epilepsy in childhood, and then there's another big peak late in life, in the elderly, which is responsible, or which is caused by, I should say, them, having required a lot of new pathologies by then, often, strokes and cerebral tumours and other brain injuries, dementias and things have an increased risk of seizures with them. So by the time you get into elderly life, you've got a higher incidence, but there's a pretty even incidence throughout adult life. People are often surprised by that. They think epilepsy is something you get as a child, but that's not the case. Just about everyone, well, maybe not everyone, an enormous proportion of people that I see have had adult onset of their seizures. So you see people in their 30s, 40s, 60s, even with abnormalities that are causing it that have been present all their life. So often, for instance, we'll see an abnormality of brain development on a scan, which you can be certain has been there lifelong, and yet someone might present with their first seizures in their 40s, 50s, even 60s or later.
Was this an influencing factor for you to do neurology, or was it completely separate?
No, look, it's, everyone's interested in neurology, right? So, the general public's really interested in neurology, and, you see all those Oliver Sacks books were enormously successful when they were out, and, people love reading and thinking about neurology, and so it is with medical students. So I was always interested in it to that extent, and I guess, my experience was coloured a little by my dad's experience, and I don't know that sort of has made it more or less likely for me to do it, but I was interested in it, and the fellow who I worked for at St Vincent's at the time, Ed Byrne, offered me a job, but only under the understanding that I do epilepsy. Now, I'm not sure whether he had any plan to that or if it was just because we didn't actually have an epilepsy service at the hospital at the time, but I thought, well, that would be a good thing to do.
How has things changed since your father's diagnosis about our understanding and management of epilepsy?
Well, there have been tremendous advances in the imaging and so on. So with the imaging, we can often find abnormalities causing seizures, and that used to be fairly uncommon, with CT scans. You'd occasionally find abnormalities, but for most part you wouldn't. And with MRI scans, as each decade's passed, there's been another leap in the proportion of patients where you can identify an abnormality. Similarly, genetic abnormalities, have been recognised and widely studied now as the cause of one of the groups of epilepsies in particular. And so those advances have been, monumental. Big advances in surgical approaches and the techniques, and I guess a lot of the causes of epilepsies are small and hard to get to parts of brain, and advances in imaging combined with stereotactic localization so that you can direct instruments to precisely the part of the brain that seizures are coming from, or precisely the abnormality you can see on a scan, and remove it much more safely than you used to be able to. That's made a big difference. Sort of equivalent to GPS for cars, but for interventional procedures. So that's been enormously important. The medications, there's been a huge proliferation of medications. I mean, as I said, in the 80s there was like 3, and now there's about 25 or more. And it's true to say that they're great to have, because the side effects of the old medications are often terrible, and people are very idiosyncratic in their responses to medications, particularly the drugs for epilepsy. And so taking the treatment's quite burdensome. The side effects can be very significant for a lot of people, particularly with regard to cognitive function and mood. And the new medications have allowed a much greater selection, this sounds terrible, a much greater selection of side effects. So you've got far more opportunity to try and find a drug that suits a person better than you used to be able to. But the overall number of people controlled hasn't changed, and this is very disappointing. So about 30% of people are not adequately controlled with their medications, despite all of these new medications we have. Now, that's not to say they haven't benefited enormously. I think, there are so many people out there who've tried all available medications and found that they either don't work for them or they can't take them just because of side effects. So to be able to have this selection and to keep increasing this selection, so very, very helpful. But overall, we haven't made much of a dent on the number of people whose seizures are not controlled, which is about a third of all patients with seizures. So that's a very disappointing aspect of the advances.
Yes, there are some advances in the selection of side effects, etc. But in the general community, do you think our attitudes to seeing someone undergoing a seizure has changed and moved on at all? Or is it still something that strikes awe and fear?
I think it's moved on a little bit, but I think generally it strikes awe and fear. And you come across this most often in the workplace, where if people have a seizure in the workplace, it often leads to terrible consequences for them, even if the seizure is quite a minor one, because the fear other people have. So, for instance, I've had directions from people working in large office spaces from their boss that they can't return to work because it was too disturbing for the other employees. The other employees required counselling, and so on and so forth. So these sorts of responses, and the burden for people in the workplace is just awful because of the stigma. And I'd say that's one of the chief complaints of people, that and the social stigma, because to be with your friends at work and to have a seizure, there's a lot of shame attached to that. So, look, I'd say no. People know a little bit more about the first aid. Seizure alert dogs and assistance dogs have gained a bit of profile, and that sort of brought a slightly more positive perspective to people's interaction with people with epilepsy. But overall, I'd say we're still sort of almost in medieval times with the approach that people have to seizures.
We continue our discussion now with Professor Mark Cook, and this is the $64,000 question, Mark. What is epilepsy?
Well, epilepsy is a synchronized discharge of a large group of neurons on the surface of the brain. So it's like a small electrical storm on the surface of the brain, and if you think of your brain as some sort of huge circuit board of all connected circuits controlling different functions, and there's a little short circuit in one area of it, it makes that area a little overactive. That's if the seizures come from one part of brain. And that area of brain then might display symptoms related to what that bit of brain normally does. For instance, if it causes movement, it might cause twitching of the area. If it controls memory or emotions, it might cause a strange sense of déjà vu or a feeling of familiarity. If it's in the vision area of brain, it might cause flashes of lights or coloured shapes. So it depends where it starts, and it might just spread it a little way and cause people to lose awareness. So they don't lose, people with seizures aren't blacking out and collapsing all the time. Most of them are having these sort of episodes where they have perhaps a warning, which consists of the sort of features I've just described. Then they might lose contact with their environment to a varying degree. It might not be completely apparent. I mentioned my dad before. It wasn't completely apparent to me with my dad when he started having seizures what was actually going on. They were quite subtle. He just said some peculiar things because his seizures came from an area which controls speech. So they can be quite subtle, and then if the seizure progresses electrically, it can involve the whole brain and people collapse and have a convulsive episode. But most adults are not having major convulsions all the time. They might have them occasionally, or that might be what draws attention to them. But most adult seizures are those minor events where people have a warning and then lose contact to varying degrees. There's another type of epilepsy, which is the genetic kind generally, where seizures begin all over the brain at once. And with that, people are most familiar with the absences that children have, and they represent the most recognisable form of that epilepsy. Very suddenly, the whole brain is taken over by an electrical discharge, which for a few seconds stops function, but very abruptly, and then there's a very abrupt offset. And the seizures that start in one part of the brain don't usually have such an abrupt onset. And they typically last minutes. Afterwards, it takes people a little time to recover.
Do we know the risk factors for why people get epilepsy?
Well, look, there's the genetic side of it, of course. So if you've got a family history of some of the epilepsies, that places you a bit more at risk. Anything that's injured the surface of your brain puts you at risk of seizures. Strokes, congenital malformations of brain, and a lot of these are very small and subtle abnormalities that for most people with epilepsy produce no symptoms other than the seizures. So most people with epilepsy are otherwise completely well neurologically. But people who have other brain injuries, for instance, people with cerebral palsy, people who've had severe head injuries and so on, these are people all more at risk of seizures.
How do we diagnose epilepsy?
Well, diagnosis is still generally based on a clinical account. which leaves a little room for error, obviously, because there are things which can be confused with it. People have convulsions for other reasons, so that if your heart stops beating and not enough blood goes to your brain for a while, you can have a convulsive episode. You can have what appears to be a convulsion with very low blood pressure from a faint even. And these are often confused with epileptic seizures. And there's some psychological situations where people react to their environment in different ways that produces events which are called non-epileptic seizures that can be very difficult to distinguish too. So, the misdiagnosis rate is still fairly high because the tests that we have are not perfect. We have EEGs, which capture the electrical activity of the brain, and that provides really a snapshot. And a typical EEG lasts for 20 or 30 minutes, but the electrical abnormalities underlying the seizure disorder might be quite infrequent. They might occur only every few hours, every few days, or possibly even every few weeks. So catching them on a random study may not be so successful. And you can try and improve that by doing a sleep-deprived EEG, and we give various provocative procedures during the EEG. We make people overbreathe and show them flashing lights, which will provoke some kinds of seizure activity, and they can be helpful. Or you can do longer EEGs. You can do an EEG where you keep people in hospital for hours or days and sometimes even longer periods to try and catch the events. And that sort of monitoring's really the gold standard. If you see people actually having the events and you've got an EEG and an ECG with it, you can see exactly what's happening. Even that, though, can be challenging, and lots of people come into hospital for monitoring and still you don't catch a seizure. We're interested in very long-term forms of monitoring, where we have implantable devices, and, I've been involved in trying to develop a device which we put under the scalp to monitor seizures in the very long term, years conceivably. And there are other solutions potentially, wearables, so watches and other devices that people can wear. Although these are really good for detecting the major convulsions because they're detecting movement, and really people with adults with seizures that I mentioned before aren't usually having a lot of major convulsions. So good for detecting major seizures in sleep overnight, which represent perhaps a special hazard for people and which are hard to recognise because there's no one else there. And maybe for children tend to have major convulsions a little more often than adults. So there might be more sophisticated ways we can detect smaller seizures with wearable devices, but at the moment I think that's in the distance.
So we have focal and generalised seizures. Which is more common?
Well, in adult life, the focal seizures are more common, and in children, probably the generalised seizures are more common overall. But about 30% of adults are having what are called idiopathic or genetic generalised epilepsies, where the seizure starts electrically all over the brain at once.
If we're looking at then focal seizures, what are some of the common symptoms people will experience?
Look, probably the commonest that you come across is people describing a sense of familiarity, often déjà vu. It's often accompanied by a strange sensation in their epigastrium, which sort of rises up through them. And they might describe to you, I saw a woman the other day who said to me, her head becomes full of sounds and images, and they're very, very intensely familiar to her, but she can't describe them. And the best way to capture this is it's like when you wake up from a dream, right? The dream was very intense and it was very vivid to you, but you can't quite recall the details of it, even though you can recall perhaps the emotion of it or the familiarity of it, but you can't quite grasp the details. And as each minute passes, it becomes more and more difficult to remember it. So that's a really interesting phenomenon about dreaming, and it's a very similar phenomenon with the minor seizures people that get that involve disturbances of memory function like that, and there's less often a disturbance of smell and taste associated with it, because smell and taste live very close to the memory parts of the brain. And of course, if they start in areas like motor strip controlling motor function, people might come along with twitching in their face or hand, and that might spread. So this spread was described by a very famous neurologist, Hewlings-Jackson, as the march of seizure activity. So it might start in the corner of the mouth and spread through the face and then into the limb and then down the side of the body and then to a major convulsions, and that's a Jacksonian march. So that progression of it, which typically occurs over some seconds, is a very useful diagnostic feature.
Mark, aside from the convulsions, many of these symptoms you talk about, people might experience these like, moments of deja vu, etc., and some of those other ones. What's the difference? Is there a threshold when we shift from just a normal part of life, inverted commas, to something that might be related to epilepsy?
Yeah, you're absolutely right. So normal people experience deja vu. So junior doctors will often say to me, oh, they're probably seizures because I ask them and they get deja vu. But of course, everyone gets deja vu. And the difference is that the patient can distinguish it from their usual deja vu. Oh. It's more intense and the content is different. And typically it occupies their whole mind while it's occurring. And also it's often associated with these other symptoms, the rising sensation, a taste in the mouth or smell, palpitations and so on. So they're very distinctive and people can remember them, and sometimes they wake them from sleep, and ordinary deja vu never wakes you from sleep. There are ways you can distinguish it, but the easiest way is to ask the patient, sure, everyone gets deja vu, and they'll say, oh, yeah, sure, but this is different.
What are some of the common generalised seizures and symptoms?
Well, look, absences are very common in children, when we see them in adults too, where without warning typically, a patient will lose contact for a few moments, typically just a few seconds, and then very abruptly return to normal. They might lose track of the conversation they were engaged in, but typically they can continue their activities. Myoclonus. Now, we all know myoclonus, this sudden muscle jerk, which you're familiar with as the phenomenon of someone walking over your grave when you're going off to sleep at night and you have that sudden jerk. And that's a myoclonic jerk. That's not epileptic, but it's a similar phenomenon. So myoclonus, like that, those jerks occurring during waking are a feature of a genetic generalised seizure disorder, usually in the upper limbs with vigorous jerking of the upper limbs. And often people will come along having had a generalised tonic-clonic seizure, and they'll be a teenager, and you'll ask them if they get those sort of jerks when they wake up. And they'll say, yeah, they've been getting them for a few years, but didn't make anything of them. And as you wouldn't, it's even people will go to the doctor and describe them, and the doctor won't think anything much of them either. So very distinctive. So absences, myoclonus, and generalised tonic-clonic seizures are the features of that form of epilepsy.
How useful is auras, like the prodromal kind of, something's going to onset and go? How useful is that?
Look, it's very useful if it's a symptom such as a motor disturbance with the twitching in a particular area or the face or hand, whatever, or if it's a sensory disturbance, and you can have a similar sensory disturbance, people might describe a tingling that starts in their foot and gradually spreads up their leg and then to their whole side. Now, if someone describes that and it consistently starts in their foot, that tells you which part of the brain that it comes from. And, Hewlings-Jackson, who I mentioned before, was really the guy who introduced all of this kind of localization, which was equivalent to the technology of MRI of its time, because it meant that people could figure out which bit of the brain seizures were coming from, which allowed surgery in very early days, without any kind of imaging, really. Now, how often surgery is successful is another matter, but it could be successful based on the description of the phenomenon. So the aura is really important. There are other kind of prodromes where people might describe for hours or days they don't feel quite right. That's a slightly different phenomenon. But the aura that occurs in the minutes before a seizure or in isolation is extremely useful information, because it can tell you a lot about exactly where the seizure is coming from. We spend a lot of time listening to the account of the patient of their seizures, and then if we've got video of them, watching the seizures to try and merge all of those features together and gain a really good understanding of where the seizure is developing and how it's spreading. So the clinical neurological part of the assessment is still really, really important in epilepsy.
There's some interesting stories that come across just historically when I was researching about the experience of divinity. Some people have this sort of a very strong sense of godliness and then had the seizure or something. Now, I'm not quite sure if that was literature or not, or if that was actually accounts, but I found that very interesting.
That's true. I mean, Dostoevsky wrote most famously about this, and, his sort of ecstatic auras before his seizures. And unfortunately, you'd have to say sort of ecstatic and pleasurable auras are pretty uncommon. They occur, but they're pretty uncommon. Sometimes people actually enjoy the experience of their aura, but that's a very, very rare phenomenon too.
I do bow down to Travis every time he enters the studio.
Now, if a patient or a parent believes they've either, seeing seizures, what are some of the useful questions to ask a patient or a parent about it?
Well, look, what you like to know, first of all, is exactly what they were doing at the time. I mean, important thing, the easiest thing is whether people were asleep, because, things that happen in sleep that look like seizures are usually seizures. Things that happen during the day, if they happened under a particular circumstance, for instance, the most important one, if something painful or unpleasant was going on, because that raises the likelihood significantly that it was a faint. And faints can be really difficult to distinguish from seizures. So they're easy things. The time of the day it occurred, with those myoclonic jerks I mentioned before, classically they occur on waking. So the timing of the events, the circumstances around it, whether people's awareness was preserved during that, whether they got a warning. Now, an important thing about the warning or the aura is the patient might experience it at the time and they might describe it to those who are with them, but then they might have no recollection of it afterwards. This is a very important feature of seizures. The seizures often start in parts of your brain which are responsible for memory, or at least they pass through those areas, and memories don't form properly. So a person can be with you and agree they had a seizure at the time, and then 15 minutes later deny to you that they had a seizure. So, and this leads to a lot of trouble for them in all sorts of situations, and I often come across it in legal situations where people are said to have done something wrong, and it's when they're in the confused state during or immediately after a seizure. And the confusional state after a seizure can be quite prolonged, and there can be very odd behaviour during that, which isn't always evident to those around them and can be quite disturbing. You can imagine having a seizure where you wander confused when you're staying in a backpackers hotel, for instance, with a bunch of people you've never met before, what the consequences of that might be. So the memory of a seizure sometimes isn't stored very well. So an eyewitness account and hearing from witnesses who were present what the patient said, what they did, whether they spoke, whether they make any noises, whether it lasted seconds or minutes, whether at the end of it they came too quickly or whether they were confused for a little while, whether there was weakness down one side of their body or trouble with speech, are very useful features, because the area of the brain that the seizure came from sometimes takes a little longer to recover. And so people might be temporarily weak down one side, for instance, if the seizure started in motor area. And that, in older people, leads to them being confused for stroke quite frequently. So getting those sorts of features of the event is incredibly useful.
Now, you mentioned EEG, but is there any other tests that are useful or investigations?
Yeah, absolutely. So I mentioned before that around the imaging, and I should sort of emphasise that. So we've got lots of great imaging with, most people have had a CT scan when they've seen the doctor or been to the emergency department, but an MRI is really the investigation of choice and has the greatest yield. And you can exclude serious causes of seizures, such as tumours and strokes and things like that. Often you'll still find nothing. I mean, it's quite common still not to find anything. But MRIs will often find an abnormality in a focal seizure disorder. There are other kinds of imaging like PET scanning, so positron emission tomography, where an injection of radioactive sugar usually is given, and the sugar is used by the brain for energy, and parts that aren't working properly show up on the scan as underactive areas. That can show up abnormalities even when an MRI hasn't. So that can be incredibly useful as well. SPECT scans are a similar sort of thing with a radioactive material that's injected, but this time during the seizure. So we do them in hospital, obviously, when we're doing the monitoring. And the material sticks to the part of the brain the seizure came from. And if you do it early enough in the event, it does at any rate, and you can see then where the seizure was actually coming from. There are more sophisticated technologies, magnetoencephalograms, MEGs, where the small magnetic fields that are generated by the electrical changes in the brain can be detected with very powerful instruments. But these are still expensive, very sophisticated pieces of equipment that are still quite rare out in the community. But they can be incredibly helpful also. So there's lots of other investigations, and they can all help. but we still come down to the diagnosis for most people being a clinical diagnosis, which is established through getting that great account of the event, both from the patient and from any witnesses that you've got.
We'll have doctors listening that aren't neurologists and patients who have epilepsy. Is there anything that they should know about or be monitoring with these patients with the medications that are prescribed by a neurologist?
Most of the newer medications don't have blood levels available. And so the most important thing is that the blood tests that people often imagine are very important to do regularly in people with epilepsy are not. So, tegretol levels, dilantin levels can be very useful because the level's meant to be a guide to either toxicity or an effective dose. Now, the problem is that a low dose can still be effective in some people, and some people can tolerate a very high level in their blood without any side effects. Some people get bad side effects even when they've got a low level of all of those drugs. So they're of limited utility, and people have got to interpret them carefully so that when persons come along unwell, having started an anticonvulsant, and someone measures the level and says it's low, so it can't be the drug, it's probably still the drug. Similarly, if the level's very high in the blood and the patient's very well, that's not a cause for panic. The level's a guide. It means most people might get toxicity at those doses, but it doesn't lead to any other great consequence. So it's often an error, I see, that people come along having had their dose increase because the levels were low, and then they become unwell. And the dose was increased for the sole reason that someone measured the level and found it was low. And you say, but you've had no seizures for 10 years? And they'll say, no. Well, why did you have it measured? And they say, well, apparently it's important. I said, well, it isn't actually important because it leads to this sort of problem. And you see the opposite, where the level's high and the dose is dropped and the person has a seizure and they weren't having any side effects. So measuring levels unnecessarily is a danger. Most of the new drugs don't have levels. You can measure lamotrigine levels. You can actually get levels measured on some of the drugs, but they don't have any close correlation with any side effect or effect, so they're not of great clinical utility. We sometimes measure the lamotrigine levels, for instance, in pregnancy, because the level can drop quite a lot in late pregnancy, so you might measure a level early on just so that you can see that you keep to that same level, whatever it might have been, if it's working later in pregnancy. That might be one indication. But generally, blood tests aren't necessary. Some of the drugs can cause disturbances of liver function, and that's especially true of phenytoin and carbamazepine. So we often measure liver function tests, but these are phenomena that happen in the first few weeks, typically, of use. You can see longer-term changes with the induction of liver enzymes, but the acute hepatitis that people are worried about usually happens with an allergic reaction and rash and so on, and people are quite unwell. But that's an early phenomenon. So I don't routinely measure drugs that people have been on for months or years. The hepatic side effects of valproate, epilim, can occur any time in the first 6 months, but are quite idiosyncratic. And, routine measurements then are a bit difficult to detect them with, but it might be justifiable to do the test for a bit longer in people taking them. The neuroanticonvulsants, though, don't have any significant hepatic, renal or hematological side effects that we worry about. And so the chief problems monitoring people's cognitive function, their mood. Some of them have been associated with quite significant mood disturbance, and interestingly, that's often not identified by the patient, or patients have been on the tablet for quite a long time, sometimes years before it's recognised that it's the medication doing it. And these can be quite profound. I have a rule of thumb, which is if the spouse or the employer calls me before I next see the patient after I've started the medication, it means that they've got a mood disturbance from my medication. It can be quite striking, and it can disrupt relationships and workplace environments and so on. So there can be quite significant problems. And it's important to advise people about them, but to keep them in perspective as well. You've got to, as with everything in medicine, when you impart this information, you've got to do it in a balanced way so that the patient doesn't go away frightened that they're going to turn into some sort of difficult monster that's going to upset their family. So you need to alert them to the fact that it's uncommon but a possibility, and that you've got lots of choices of medications so that you can move to a different drug if it's not suiting them. That's the most important thing to understand. I say out in the general medical community, there's a lot of fear of anticonvulsants. I think as well because there are a lot of new ones and people are very unfamiliar with a lot of the newer ones and their side effects and they worry a lot about them. And we spoke earlier about the pregnancy side of things, and of course that causes great concern. And that's an ongoing challenge, and it's an area where there's still very little information really about a lot of these neuroanticonvulsant medications.
So far in our discussion, we have reflected on the past, we've reflected deeply on the present state, but now with Professor Mark Cook, let's turn our attention to the future of our understanding of management of epilepsy. Is it true, Mark, that a lot of people with epilepsy can actually be having seizures while being unaware of them?
It's common to see people who've come along with a major seizure, and when you ask them, they give a description, or those around them give a description of minor episodes where they've been losing contact for occasionally you see them where they've been having them for months or years, and no one's made anything of them. It's interesting. And the myoclonus that I mentioned before in teenagers, the average duration of the myoclonus prior to the diagnosis is about 18 months. So it's quite common for people not to have a diagnosis recognised. And we've discussed before that people are often unaware themselves they're having seizures, or they might deny them, or they might be quite confused what everyone else is talking about when they're describing what they see. So that can be very interesting. I mean, I remember seeing a very elderly lady once, and we did EEG monitoring on her to prove what I thought were seizures, and they were. And when I told her daughters, who were sort of adult daughters, who were nurses, they were very angry about this, and they thought I was wrong. And I said, well, I'm pretty sure because I've got recordings of them with an EEG. And I described them to them, and they said, oh, no, but she's always been like that.
Oh.
And I said, well, that's right. So they call them, these sort of phantom seizures where people have them for a long time and they're just accepted as part of someone's normal behaviour. In some societies, in times gone by particularly, they were thought to represent perhaps a religious experience or, a special spiritual element to someone's personality. So, I remember seeing a young woman once, and when the parents described them to me, and when I said, "Well, these are seizures. I mean, what did you think they were when you saw them before?" And they said, "Well, we just thought she was psychic because she'd have this premonition and she knew everything that was going to happen because people were describing this deja vu, and then she'd sort of zone out, and we thought she was just having visions." These weren't particularly religious people, but you can see that the level of sophistication around our understanding of epilepsy is pretty poor, and because most people don't understand that seizures involve these kind of episodes, they don't recognise them when they do see them. So you hear some interesting accounts.
When are patients at increased risk of having seizures?
Well, look, sleep deprivation is the easiest way to provoke seizures, and often you see people have their first big seizure, for instance, when they've been under unusual circumstances of sleep deprivation, international travel, an intercurrent illness, or something dramatic's happened which has deprived them of sleep for a significant period. So that's quite common. Stress also is very commonly reported by patients to be a provocative factor, and possibly because it disrupts sleep. Stress is an important clinical thing to identify because managing it's a very important part of controlling seizures. People who are depressed have a slightly higher rate of seizures, and people who have seizures have a higher rate of depression. So, that's a two-way relationship.
Can we predict when a seizure is going to happen?
Well, this is something which has interested me for a very long time, and we started a project around seizure prediction a long time ago, which really is what led to this implantable device that we have, because we were involved. We started doing a study on this, and we decided after a few years that in theory you could predict seizures, but in practice it was impossible because you couldn't collect enough EEG data because you needed to have lots and lots and lots of EEG data, more than was practical to collect from sticking electrodes on someone's scalp. And putting electrodes in someone's brain you could do, but you couldn't do it for long periods because there was no way to store or transmit the data. But then when we got to the point of figuring that it might be possible, but it might be too hard to do, a company came along called Neurovista, who had a device that could capture direct from brain and store and transmit the data. And with that study now over 10 years ago, we were able to show that it is possible to predict seizures. So you can predict seizures with the system that they had on average about 90 minutes before the seizure, and for some people, some hours beforehand. For some people, only a few minutes. And at that time with that study, we couldn't predict it for some people at all, but for most people, we could predict them pretty well, and for some with 100% accuracy. That wasn't a great enough level of success to allow the company to develop, and so the company collapsed. And we continued looking at our original plan then, because we figured that the technology advanced to a stage where we could capture the data using other techniques that weren't so invasive. Because what we saw from their study was that getting the electrical activity directly from brain was important, and great if you could get it, but it was more important just to have some electrical activity and being able to identify when the seizures were happening, because there was a pattern to them. And if you identified the pattern, which was highly individual and complex, you could start to predict seizures pretty accurately for a lot of people. And that could be further supplemented potentially with data from wearables, looking at heart rate and other features of seizure activity. So there were lots of things that you could do that would allow you to forecast seizures to some extent, and these methods are just getting better. And I think, understanding of these patterns underlying these seizures and how they occur is really something which has evolved out of the work that we've done over the last 20 years in this area.
So how useful are now wearable devices? Where are we at with that? Is that sort of just generally patients are able to use them, monitor? Where are we at?
Generally, they're useful for monitoring major convulsions. So, the problem with them is that, major convulsions involve jerking of the limb, and obviously lots of things cause you to shake your hand, brushing your teeth or hair, and, if you're out running, lots of things might cause movement, which might be detected by a wristwatch type worn system. So these are a problem. There are devices which you can stick onto the scalp to record EEG, but they're obviously things you can wear only for a certain time, stuck onto your scalp, and also they also attract a bit of a stigma too if you've got devices stuck onto your forehead that are visible to others. So those kind of wearables might be helpful in some situations, but really wearables haven't yet made a big dent on epilepsy management.
And there's home monitoring devices. Are they useful?
Look, we set up a home monitoring service a while ago, and around the world, ambulatory monitoring, where we do the video EEG recordings at home, are incredibly useful. I mean, you learn so much about people's seizures. You see not only the electrical and video-based clinical changes that we capture in hospital, but you see how it affects them out in their day-to-day life, and how it affects their interaction with others, and how others respond to them. And that's been really interesting too, because it's also apparent that witnesses aren't as good as we thought they were. When we look at the videos, and these are generally people at home with friends, family and carers, we can see about a third to 40% of the time those around them don't recognise the seizures either. So it's intriguing, and sometimes that's even when they're quite substantial. Sometimes it's because they're seeing them, but they're not reporting them. And this whole problem of people having seizures and them not being aware of them, them not being witnessed, or witnesses not identifying them, or witnesses not recording them, means that it's very hard to monitor the effects of your treatment. And, it's increasingly apparent that one of the reasons we've not made much headway with treatments in the past is because we don't really have much idea what's happening to people's seizures. We think we do, and they think they do. And again, to get back to the original story, it's like my dad would go to the doctor and say, I'm doing really well, haven't had any seizures. And you'd say, oh my God, you've had heaps of seizures, none of them you remember. So, and vice versa, because a lot of people are having events and they think, I wonder if I just had a seizure, then I better record that as a seizure. So people overinterpret a lot of normal day-to-day experiences. I just had a bit of deja vu, then I wonder if that was normal deja vu. Well, it might have been related to a seizure. I'll record it as a seizure. So it's distorted by under-reporting of events and also over-reporting of events, and this is very hard to manage. And that's why we need better systems and devices for capturing and recording seizure activity.
Let's assume we've got a patient who's stable, who has epilepsy, and they're on medication. Is there any times of their lives, such as like puberty, pregnancy, menopause, where we can predict that their medications may need to change?
Look, not usually. Pregnancy, you might need to change some medications, particularly the lamotrigine and even levetiracetam levels can drop in pregnancy. So we often look at the levels in pregnancy. Outside that, they're around puberty and menopause. Not particularly, the pattern of seizures might change a bit, but I'd say overall we don't see any major change in pattern of seizures with those big events. More important to warn people of is I always warn people that at times of their life when they're under unusual stress, when they're sick with something else, when they're sleep deprived, and the most common sort of circumstance for that would be around international travel, crossing time zones, there are times when, I tell people to take extra care. And because for most people driving is the most dangerous thing you do, followed by bathing and swimming, I say, when you've been in that situation where you are at more risk, there are times when for those days you shouldn't engage in anything dangerous. Because if you have trouble, almost certainly that's when it's going to be. So educating people about when they're more at risk, and missed medications, of course, is an obvious one. But if they've got unusual things going on in their life, then there are times that they should be extra careful, and especially avoiding driving and so on.
When a patient is referred to you or a neurologist, what is useful to be sent for the first consultation?
Well, look, any old correspondence that they've got relating to the events, and obviously if they've had EEGs and scans, they're incredibly useful. Getting accounts by others that are written. So for me, getting the correspondence from other people who've seen them, because often there are little fragments of information in there which might provide valuable clues as to what's actually going on. Correspondence from those who've previously provided assessment, eyewitness accounts, extremely useful. Nowadays, a lot of people capture these things on videos. The lady I spoke to you about at the start, who gets the thoughts and noises in her head, she's quite elderly, and some elderly friends had a phone video, and they'd not done a great job of capturing the video, but they captured a few grabs each lasting about 5 or 10 seconds, and they really told you all you needed to know, because the features that were captured in the videos really left you in no doubt that she was having a seizure. So her phone cameras are probably a bit underutilised. It's surprising. I often say to families, have you ever videoed them? They go, oh yeah, I never thought of that. Everyone photographs everything now, but for some reason it doesn't occur to them to try and capture these events. But that can be really, really helpful, both in identifying things that are and are not seizures.
I guess you'd feel I should be helping them rather than filming.
Well, you know what? It's an interesting thing when you see people having seizures, and this gets back to the stigma thing, When you see people having a seizure, people stand back. When you see someone having a heart attack, people rush up to help them. It's a really interesting, this sort of really deep, visceral response that people have when they see a seizure. It's like seeing a spider or something, they've got this inbuilt reflex where they'll be frightened and they'll stand back. So you don't so often see people intervene. And you might have witnessed this yourself, seeing people have a seizure in public places. I remember, seeing one at a tram stop and another at the market down in the city, and everyone sort of stands back, they don't know what to do, better not touch them, you might catch it, sort of thing.
Do you think also with the brain being a prediction machine, someone having a heart attack, we kind of know what's going to happen, whereas this is in that situation where it's unpredictable. We just don't know, and that might paralyse us. I don't want to let us off the hook.
It is a very common thing, and unfortunately what a lot of people do know about seizures is wrong, and that is that you'll swallow your tongue.
Yes.
And so sometimes people, this isn't quite so common now, but it was the only thing most people knew about seizures, is that you'd swallow your tongue. So someone had to rush up and stick, a knife or a fork between your teeth to protect you from choking. And that's because of the terrible choking noises that might occur, particularly towards the end of the seizure. A lot of saliva is produced, but you don't swallow your tongue. And a lot of damage is caused to teeth and people's fingers by people attempting to retrieve the tongue. People often bite their tongue during a seizure, but that's a separate problem.
I'm glad you mentioned that, because I had one last question, which was about the pencil or the pen in the mouth. But thank you.
Stay away from the mouth.
Great.
Yeah. People need to wait for the seizure to subside, for the convulsive movements to subside, and then lay people on their side in the recovery position and let them wake up. Avoid restraining them unless absolutely necessary for safety, because people are often confused and combative in that phase, and that's when trouble sometimes develops.
Mark, just finally, apart from that, which is very sage, is there any advice for doctors or patients about epilepsy you'd like to leave us with?
Learn a bit more about it. I think it's from the doctor's point of view, it's an interesting condition that you can understand really well if you know a little bit more about it, and to understand the features of it and how it lets you figure out which part of the brain and which kind of seizures. It makes it a lot more interesting to deal with, and when you're interested in it, you'll do a better job of finding the right treatment for the patient. For the patients, learn a bit more. You'll be less worried. You'll understand your condition better. And you might even know more than your doctor about it after a little while.
Professor Mark Cook, thank you very much for joining This Medical Life.
Pleasure. Thanks for having me again.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/The Real Steve Davis. This has been a Pathnotes Proprietary Limited production.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.